The way this one is going to go is a little different than what we've done before. We're going to have a presentation from Dr. Edens, a short presentation from Blake Heflin, and a slide and maybe a little comment from Don Herring. And then we'll open it up to questions, and Dr. Gear and I will answer questions, and I'm going to pull on some of my other colleagues too if I need a lifeline. So let's get going.
Hi, my name is Georgie Edens, and I am a clinical psychologist, but I'm also a patient. So today I'm going to be speaking to you as a fellow patient. I would like to say what was spoken earlier, that I wish I had heard Dr. Penna 7 years ago when I had my surgery. I was diagnosed I had my surgery 7 years ago at the University of Virginia. Dr. Ed Oldfield, who has passed on, did my surgery, and I'm very grateful. I've been in remission. I had a pituitary macroadenoma, and I had undiagnosed Cushing's disease for at least 15 years and maybe longer. So I wanted to put up a picture. This took a lot of nerve for me to bring my pre-surgery picture. There I am in the middle, before my surgery, active Cushing's. Then at 9 years before I was diagnosed, I had gastric bypass surgery, and in the red t-shirt is the day I had my gastric bypass. So notice how Cushing-y I look at that stage, not to mention the middle one. And then I lost about 80 pounds and gained half of it back, and was not diagnosed until 9 years later. And someone mentioned about pictures. You can look at pictures of me before I became active Cushing's. Then you can see the middle one at the height of my Cushing's before gastric bypass. And then you still see in pictures before my surgery, even though I lost weight, my face is still round in those pictures. And now, that was one of the mainest differences that you will see is the face, how different it was after my Cushing's surgery. So I am in long-term remission. I have had no radiation. I have had no recurrence. I'm checked every year now. It was every 6 months. I went back for 5 years to UVA, and she let me go, meaning she didn't let me go. She told me to have my endocrinologist to do my testing every year, and then she said, Dr. Vance, who is my endocrinologist, said, you will probably know if you start to have Cushing's. You'll have symptoms, and we will do anytime you want to come down here and do testing, please come back. And I said to her, I hope I never see you again. Thank you very much. But after going to doctor after doctor, and I know that there's many people in here had the same experience, I was just told you have metabolic syndrome, you need to diet, you need to exercise, you need to lose weight. Doctor after doctor after doctor. And finally, after realizing something was wrong with me, I went to this endocrinologist. I'm from Washington, D.C. area, Metro D.C., and I said to her, something's wrong with me, and I'm not leaving here until we find out. And she was like, okay, and so she started running all these tests, and nothing showed up in the normal one. So eventually, after I kept asking her, would you do this test, would you do this, and she just happened to find that I had some adrenal nodules, and then she did the cortisol testing, the 3 tests, I was high, then she did the MRI and had a macroadenoma, which I'm not surprised given how long I had the surgery. And I'd like to say that what I'm going to share with you is my quality of life, long-term remission after 7 years. And I want to emphasize this. Every one of us in this room who's a patient is like a fingerprint. There are no 2 patients alike. Even though we all have some form of Cushing's disease, every one of us is unique. So I'm going to share my experience as a patient who is I was diagnosed at age 62, so if you do the math, you'll figure out how old I am. Actually, I was at age 63. So I had at least 15 to 20 years of high cortisol levels in my life. So when we talk about new normal, I have a hard time remembering what normal was for me going back so far. But I want to just mention that I had already been treating my depression, which I had all those years, and because I'm a psychologist, I went and I was been treating for my depression. And then I found out that depression is the #1 psychiatric symptom of Cushing's patients, pre and post. And finally, I am now at the point where I am accepting the reality that this is my new normal now. I don't know what I'm going to be like. I just turned 70. I know I don't look that old, right? It was pretty traumatic, though, I have to say. 70 seems a lot worse than 60s. Oh, well. So what I want to do is talk about my life. I'm going to share my top 4 symptoms of post-Cushing's quality of life that I'm dealing with right now. And then I'm going to talk a little bit about coping and what I found effective and helpful to me to adapt to my Cushing's disease. I want to just read a couple of quotes from the literature. What happened to me was I got into a Cushing support group, the Washington, D.C. Metro Cushing support group, about 3 or 4 years after my surgery. And that was an amazing experience to finally meet other Cushing's patients. I had never met any other patients until I was in this group. And I would strongly encourage you to get into a support group. I felt like I'd finally found people who understood what I was going through. In fact, I had a moment. This is the first time I've been in a large group of Cushing's patients. And I had sort of a moment yesterday. In the late afternoon, I went to get a drink after several of the presentations and sort of walking around and looking at people. And I teared up because I thought, they all look like me. I felt at home. And I suddenly realized I feel like I'm kind of with my family here because I feel like people understand what I've been going through. And this is like 7 years after my surgery. So I'm just grateful for anybody who's here at the earlier stages because now you can actually have your experience normalized by people who know what you are going through. And that is so important. And I want to just add that my husband is a wonderful man and he is very supportive. And my friends, I have a very good, strong social support network system, but they do not understand my Cushing's. And as much as I try, and I've actually stopped trying because you don't want to wear your friendships out by talking about it all the time. That's why you need a support group. But I have said so many times to my husband, I wish I'd like to know if anybody in this room has had this thought. I wish you could just live in my body for one day, 24 hours. I have said that to him so many times because I know, I just want him to understand. And we all need to be understood, don't we? That's a part of being human. The 2 things I tell my clients is we all need to know I matter, that you're important, and that starts when you're born and your mother looks you in the eye and she smiles at you and she feeds you. And we need to know that I matter our whole life. But the second thing is to feel that we're understood. And especially with Cushing's disease, you just won't find people who will understand. They'll understand chronic illness, but they won't understand Cushing's disease. So I always advise people, let go of your expectations for people to understand, and especially for those of you who are here with your caregivers, be grateful for your caregiver, but let go of your expectation for them to really, really understand, and be grateful that you have someone in your life who cares enough that they would come to this conference. Now, I have to admit, my husband offered, and I told him no. I didn't want him to come. So I don't know why. I think if you met him, you'd know. He's an extrovert off the chart, and he would just talk to everybody. And so I want to just read. So what happened about 3 years ago, I did not know what was wrong with me except that I thought I was going to be back to normal. And guess what? There was no normal. I was not back to normal. And so I started researching quality of life in Cushing's disease long term. And guess what? Surprise, the literature is there. It's very small. There's not a lot, but there is literature there that does talk about the fact that long term, many people do not normalize and get back to their pre-Cushing state. I want to read 4 quotes, and I'm not going to list or quote. I'm not going to give you the article, but if you want this information, you can email me, and I have a whole list of references that if you want to email me, and I will send it to you. If you look on your presenters' bios, you can just email me at georgie@georgieedens.com. georgie@georgieedens.com. So I want to read a couple of quotes from 4 different journal articles. Conclusion of one was, over the last decade, it has become evident that quality of life is severely affected in patients diagnosed with Cushing syndrome, and many may not normalize despite successful treatment and endocrine cure. I mean, we've been hearing this throughout this conference, but it really is important to know that the quality of life is very possible that it will not ever return to what it was before. And I want to say this too. I am older, and I've had Cushing's I had Cushing's a long time. And if you're younger, as it's been communicated in these seminars, the younger you are that you get it, and the sooner they catch it, and the sooner you have the surgery, the outcome, I personally believe, is much better than where I am right now. So another article says, all these observations seem to validate that Cushing syndrome, even after resolution of hypercortisolism, has long-lasting adverse effects on the central nervous system, suggesting that depression, anxiety, and neurocognitive impairment may still dominate the clinical picture even after disease remission. Thank you, Dr. Penna. She just explained all of this. I wish I had heard this a long time ago. But as you all said, just hearing her presentation, one person said it was worth coming here or something like that, just to hear her presentation, because I knew nothing, absolutely no information was given to me about the long-term effects of Cushing's disease. They gave me a lot of information about the surgery and my post-surgery, what I call train wreck, which I felt like for 2 years I had been in a train wreck. And especially when I went off my hydrocortisone after 6 months, and from that point on is when the train wreck really took effect for me. And I could barely move, I could barely walk, I was in pain all over my body, and I just want to tell you, it gets better. And it's slow, but it does get better. But after 2 to 3 years, I wasn't completely in any way the way I was before. So I want to list some of the things that I experience now. I want to finish this one article. It says it should be highlighted that psychiatric and mainly neurocognitive disorders, even long-term after Cushing syndrome remission, although generally improve, may persist or even worsen, contributing to the persistent impairment of quality of life. Therefore, long-term follow-up and careful periodical investigation of psychiatric and neurocognitive symptoms should be always considered in the management of Cushing syndrome, both in the active phase and after the disease remission. And I would like to say I'm so grateful to hear that Emory's program sends your patients to the neuropsychologist, because it was never suggested to me to see a neuropsychologist at all. Another quote, quality of life is significantly impaired not only in patients with active, but also in those with long-term remission, regardless of the presence of hormonal deficiencies and treatment strategies. And then the last one, the last article says, within its great complexity, a conceptual shift from merely biomedical care to a psychosomatic consideration of the person and his or her quality of life appears to be necessary to improve effectiveness. It is time to translate the research evidence that has accumulated into clinical practice initiatives. To patients who show persistence or even worsening psychological distress upon adequate endocrine treatment, psychiatric psychological intervention should be readily available. Applying interdisciplinary expertise and addressing the needs for rehabilitation would markedly improve final outcome. And I think I translate that into saying, I think it is imperative that you see a psychologist, and if you have depression, and a psychiatrist to help you moderate what medications, and one person came up to me before this seminar and said, I think it's really important that psychiatrists that we tell people that psychiatrists are the ones that really know meds. And you can go to your primary care physician, but they don't know meds. You need to go to a psychiatrist who can, and here's something that I do in terms of every doctor that I go to, and I have a lot, I take them journal articles. They love journal articles. You can say to them, I have Cushing's disease, you have cognitive defects, you have this, that, the other, but you hand them a journal article, and they're like, oh, okay, yeah, all right, you really do. Now, I mean, they know that you do, but as you probably know, I have found that many doctors don't know that much about Cushing's. That was brought up earlier in a seminar yesterday. And therefore, when someone said today, when you talk about your symptoms other than just the overproduction of cortisol, but all these other residual symptoms, they really do not understand it or know much about it. And so, I mean, I've had doctors say to me, I'll ask, how many Cushing's patients have you had? And they'll say, well, 1, 2, and there's a few that will have more, but your doctors, and you don't expect them to really know about Cushing's disease because it's so rare. Okay, I want to transfer into my next point, which is what my new normal is. And here's my top 4: fatigue, cognitive function, depression, and muscle weakness and pain. And I'm just going to go back and just talk a little bit about each one. But the muscle weakness and pain, the muscle myopathy of your proximal muscles, which is these muscles, the ones that are closest to your trunk, my thigh, my muscles, and these arms, I still have weakness there. And I know some of you understand what this is like. You get on the floor and you can't get up unless you pull yourself up by a chair or something else. I unfortunately found out the hard way that I couldn't run. Now, this was probably 4 years after my surgery. My husband said to me one day, why don't we all go, there was a group of people who were going to go play tennis together. And I went, come on and join us. And now I'm a tennis player. I was the junior high school tennis champion in Hopkins County, Kentucky, 8th grade. I have a little trophy. And I have to say that's the only trophy I ever had in my whole life. But anyway, I was on the tennis team in high school, not in college. But anyway, so I thought, okay, I don't know. He goes, yeah, honey, you're a good tennis player. So we go to play tennis, and we were doing foursomes, and I could return the ball. But when it was hit out of my range, I started to run, and I couldn't run. I mean, this was the first time since my surgery I'd actually tried to run. And it was like my mind said, run, and my body went, what's that? I don't know what that is. And I was so embarrassed and so humiliated, and my husband said, oh, these people, they understand. But my self-esteem, which was already in the basement after having undiagnosed Cushing's, it was really hard for me to just smile and just go, it's my Cushing's disease, and they're very understanding people, but I came home humiliated and embarrassed, thinking I'm a terrible tennis player. And I'm going to come back to this illustration in a minute. On the fatigue, I think there's just not much to say about that, except that and a lot of this, who knows how much of this is my age? Because even in the cognitive function, you have normal cognitive decline as you age. And I found that I cannot complain about my cognitions, my memory problems to any of my friends, because they go, oh, I do that all the time. And so I'm sure that it is partially that, but it's impaired in a very specific way. And I will get back to that in a minute too. But what I want to do now is tell you, and the depression, I have been working with my psychiatrist, and it's very difficult to get that under control. And I will just admit that it's something that I am constantly dealing with. And if I get sick, like I have chronic urinary tract infections and sinus infections, and I never had any infections before I had surgery, or before I had surgery. And I'm constantly plagued, but when I get a urinary tract infection, my depression just goes way down. And I am just wiped out, and I want to exercise, but I can't. And so I just want to tell you that these are things that we have to constantly be aware of and adapt to, and sort of take care of yourself in terms of giving yourself a break when you have these periods where you just can't function. How do you cope with Cushing's disease? Coping is really the way we adjust to changes, stressors in our life. And what I have found is there is maladaptive coping and adaptive coping. And I always tell my patients, even if you have maladaptive coping strategies, that's good, because you're doing something to try to help soothe yourself. And so what we want to try to do is find coping strategies that actually improve your functioning versus coping strategies that do not and actually make you worse. For example, in my little thing of unhealthy coping strategies, what I find that I will tend to do if I get really tired or low is eat to comfort myself. But also caffeine. I am very sensitive to caffeine, but it gives me a lift. And so I like to drink it because it gives me a boost mentally and physically. But then what happens later is that I go womp down, and I wake up the next day and I feel like I've had a hangover. So that's one that I struggle with, because sometimes I just take caffeine because I want to be feeling, and it makes me feel good, but it doesn't help me in the long run. So all of us know what our unhealthy, self-soothing, adaptive, maladaptive behaviors are. Here's some suggestions that I have for you. Get treatment for your depression. You've heard Dr. Penna talk about it. Don't get over the stigma if anybody still has that for depression. I always tell my patients, it's strange that people think that anything that's wrong with you from your neck down, you go and you get help for. If your pancreas doesn't function right, anything else in your body, but people don't understand that from your neck up, your brain is an organ, and if it doesn't work right, you go get help, but you go to the psychiatrist, and you go to someone who can understand the brain. So get help for your depression. My little phrase is make peace with reality. I used that about halfway through my marriage, after 25 years of marriage, when I started to make peace with reality. Things got a lot better. He didn't change, but I did. And so what I think is important to do is what the psychological term is cognitive reappraisal or cognitive restructuring or reframing. For example, with the tennis example, instead of me saying, I can't play tennis, I'm a terrible tennis player, now I say, well, I can still play tennis. I just go and I volley with my husband or other people, and I hit the ball back, and I really am a good tennis player, and I know how to return the ball, and I'm going to have fun. Instead of avoiding it altogether, I have reframed it and basically taken, instead of a negative view of it, I have a positive view, but it's based on realistic optimism. It's realistic what I can and cannot do.
Excuse me, Dr. Evans, I just wanted to, we do have a few questions. I'm just going to ask if we can move through
Okay.
the other speakers. No, please finish. And then I just want to remind everyone, after we have all the speakers an opportunity to speak, because I know we're on a little bit of a shortened time frame, then we'll open it up for questions.
Okay.
Thanks, sorry.
I'll just end with advocate for yourself, get help, make peace with reality, join a support group, practice gratitude. It's really important to be focused not only on the negative and what things have gone wrong in your life, but be grateful every day for what is good in your life. And the studies on gratitude in psychology show that it definitely improves your emotional functioning. And then grieve the loss of what your life once was. And then after you grieve, then you will get to the point where you accept where you are, and then your Cushing's becomes part of your narrative, just like anything else in your life. Thank you.
All right, I will introduce myself next. I'm going to keep it fairly brief because I do want to get to questions for you all to ask us anything that you would like to know. Short things about me, still not a doctor. I'm still 25, and I still work with Adrenal Insufficiency United. So what we do is bring patients together. We are a unifying entity that brings all different types of adrenal insufficiency together towards a community. So just like we were hearing about finding your support group, I urge you to do that. Now, we have one if you want to join ours, but there are hundreds of support groups, and I urge you to find yours, to find your community and share your story. That's the best thing you can do for the furtherment of your disease, is to share your story. So quickly, as you all know, diagnosing rare disease takes on average, depending on who you ask, 5 years and 8 doctors. But at the end of that, you get a new diagnosis, right? It may be your 7th or 8th or 10th diagnosis, so you're not always willing to say, yes, this is my definitive diagnosis, finally. You're a little skeptical, right? But you move along with your medications, with your quality of life, with the new you. So I want to just tell you quickly 2 different stories that I have. Finding your new diagnosis is hard, specifically with Cushing's. It's an invisible illness. If you're not showing true Cushing symptoms, people don't know what you have. And even if you are, we don't always know that it is Cushing's. It could be a number of different things. So I want to tell you about a gentleman, we'll call him Mike, because HIPAA still applies to us. So Mike is 17 years old and was diagnosed with Addison's disease. He was a star soccer player. He had straight A's all through high school. When his symptoms started to hit him, the low cortisol, the autoimmune response, he found that he couldn't go to soccer practice. He could only run and participate for about 15 minutes before being absolutely exhausted. And that completely changed Mike. He started getting into crime. He's now been incarcerated 3 times. He's still in high school, he's doing well, but it's because he hasn't found his community and his home. So he has a great mother who reached out to a few of us over at AIU and was just seeking help for the son. So we were able to get him with another group of kids his age who have a similar diagnosis. And they were able to get together and share their story and say that things get better. You can't play soccer as much as you used to, that's fine, but you have to find your new normal. And as we heard earlier, that new normal is different for everybody. It can be anything from working a part-time job, working a full-time job if you're able, to we have people that run the Ironman or swim and bike the Ironman. I personally find weightlifting helps me. So with my disease, I have an increase in testosterone, so it really helps with weightlifting. Now, I don't have to take extra steroids for it. But I want you to find your silver lining with your disease. If it's that you have more time and you can bring other people together, that's what you need to do. Right. And yeah, I just want to keep it kind of brief so we can open it up to the floor. Do you want to introduce yourself?
We're going to
still say it's morning because we haven't eaten yet. So good morning, everyone. I'm Dawn Herring, and I'm a licensed marriage and family therapist by trade. I live and work in California, and I work for the military. I'm also a Cushing survivor. I had transfemoidal surgery in 2014, and I was on hydrocortisone replacement therapy for 2 years post-op. I continued to work during that time, which was an interesting experience. Because yes, a new normal had been found. And I remember going for my post-op appointment with the ear, nose, and throat surgeon, and she said what I thought was so useful. I didn't realize it at the time. She said, "You are going to look deceptively normal and feel extremely tired." And so I kept that in mind. I sort of laughed at her at the time because I felt pretty good. They hadn't decreased my hydrocortisone at that point. I remember I was baking scones and listening to 80s rock music, and then I think the next day I had to go from 60 milligrams down to 20 or 40, something, and I thought, oh, this is what this feels like, this new normal. But I kept that in mind, and I think that this is going to be a PSA for my breakout group this afternoon. We're going to talk this afternoon about self-care, self-compassion, and an active grieving process. How do we move through this grieving process? How do we do some very strategic self-care? And part of that for me is self-compassion. How are we gentle with ourselves? I've always been a very type A, high performer, and I studied dance for most of my life. And prior to my diagnosis, I was told that I needed a total hip replacement in 2013. And I'd gone from mild to severe degeneration in my hips in 9 months. So I had my first hip replacement in 2013. I had transfemoidal surgery in 2014, and in 2015 I had my right hip replaced. So this was the end of dancing ballet, because you gotta leap and you gotta run, and neither of those things could I do. But I was driving to the gym one day, battling my muscle loss, and I thought, I'm bored, and I don't want to go to the gym, and I'm not really a gym rat at all. And so I called this dance studio, and I said, do you teach private lessons? Because I didn't want to dance in front of people. I didn't know how that would go. And they did. And they took me in, and I started Latin dancing. And you don't have to leap, and you don't have to run. And so what I would say in terms of quality of life is, yes, there's a new normal. And one of the most important things I have found is to be incredibly gentle with myself, as gentle as I am with my patients. My challenge is, can I turn that compassion, that patience back on myself as I change, as I heal? And I think also, I was spoken of this morning by Dr. Penna, that cognitive therapy is so crucial. It's like going to the gym for your mind. Right? And it is a discipline, and it doesn't happen overnight. But this afternoon, we're going to talk a little bit about cognitive therapy and also some other treatment modalities, just to help us process and move through this whole process of grief, identifying our new normal. So that's my PSA for this afternoon. So if you are wanting to come, it will be a great time, and we would love to have you there this afternoon. So thank you.
So we're going to open up to questions, but before we start that, or as we're getting the microphone moved around, I just wanted to make a comment, and that comment is that it is true that the literature suggests that quality of life does not improve or normalize to sex and age-based norms, which is what we're comparing against in some patients with Cushing syndrome. But I'd like to give everybody the thought that it's possible for everybody to get back to normal. I have a lot of patients who get back to normal, but they get back to normal because we think about every single thing that's not right, and we try to address it. And you may have hypertension. Once you don't have the hypercortisolism, we treat that hypertension just like anybody else's hypertension. So don't be fooled into thinking that I have X, Y, and Z, and everything is lost, and I'm never going to be normal again because of that Cushing's with its long-lasting effects. That may or may not be true. So I urge all of you to make an effort to try to get as close to a normal as you can, and I think in many cases you can. And I totally endorse the CBT recommendation, and that really does work best when people sort of perseverate on the same sorts of things that aren't helpful. But if you're flat out depressed, seeing somebody who can give you talk therapy as well as medications. If you can't move and you want to run again, I make my patients learn the sit to stand maneuver before they leave the hospital after surgery, which is what we do when we test for strength. You sit in the chair, you can't use your arms, you stand. You sit in the chair, you stand. You do it 20 times and you feel like you can't do it anymore. But if you keep doing that, your quads and your butt are going to get stronger again, and that will make it easier for you to start moving more. And people don't realize how badly out of shape you get when you have Cushing syndrome. And you have to start very small and make baby steps. But if you start and just remember the 2 steps forward, 1 step back idea, gradually with doing some things at home and seeing a physical therapist, it can make a tremendous difference in your life. So please just don't give up just because you've had Cushing syndrome. I think there's a good life out there for everybody. By the same token, some of us will have true limitations that can't be overcome. And then I think in that setting, you do have to work through it, accept reality, see where things are, go through the grieving process, and come to a new appreciation of the gift of your life as it is. So just a couple of my 2 cents. So we'll take questions.
Hi, I'm 2 years post-BLA. 4 years ago, I had surgery. But my question is how to overcome fatigue, because I have major fatigue. And I think that major fatigue is leading to depression, or is the depression leading to the major fatigue?
I'll take them. I'm sure others will have some ideas. So first of all, I think that depression and fatigue both go back and forth, so that I think it can be quite true depending on the person. It would be important to make sure that none of your medications are causing fatigue. Many times the things that we give to patients that have good effects also have that bad effect. And I think the better nutrition people have and the better physical activity and pleasures that you have in your life, things to look forward to, I think those are things that can help.
I would just echo what Dr. Neiman says, that one is optimizing your replacement, and there's always something to fiddle around with, whether it's your type of your glucocorticoid replacement, the dose, the timing, adjusting. If you take it twice per day, maybe 3 times a day would be better to, adjust that. And then also the 3 pillars: diet, exercise, and sleep. As we've been talking about, it's hard to try and it's a vicious cycle where if you're feeling very tired, you're not going to want to exercise. But on the other hand, if you're more active, you're using energy and will also create energy. A healthy diet, which actually I'm talking about this afternoon, diet and exercise, and the real effects that it has in your brain. Chemical effects, and then sleep. It's stuff we know about, but really looking into sleep hygiene, not just the amount of hours you get, but the quality of the sleep. And there's lots of things, and I know that's an issue that comes up with Cushing's a lot, but if there's difficulty with falling asleep or staying asleep, or you're waking up tired, you can really work on your sleep hygiene. Things like having a set schedule, try and keep it like weekends to weekdays pretty similar, trying to wake up and get sunlight on your face to kind of reset your daily clock. In the evenings, all of us, our circadian rhythm is like non-existent in the modern era because, it's like light all the time and there's screens and we're like on our phone constantly, and just trying to have real habits where you have some, real discipline in terms of having where you sleep a cool room, because your body temperature needs to go down when you sleep, a cool room, a dark room, having your screens and devices out of the room, having a period of time in the evening where you turn them off and you can kind of transition into sleep. And I don't know if sleep is an issue for you at all, but it's very important to really prioritize that. We know now that there's a very strong relationship between sleep quality and weight and metabolic health and brain health. So those are just some practical suggestions that we all need to remind ourselves about.
Just maybe make 2 other short points about sleep. First of all, almost many patients with Cushing syndrome either have or develop sleep apnea during or afterwards because of the short neck and the increased weight. And sleep apnea is my number 1, 2, and 3 diagnosis anytime somebody comes into me and says, I'm tired all the time. And I think that needs to be excluded in anybody with really severe fatigue when it's characterized as, Eliza said, about waking up tired. And the second thing is, remember, beds are for 2 things, and they both start with S. And that's all. Not reading.
We're going to be talking about those S's this afternoon, by the way.
Thank you for that great stuff on sleep, because it is really. This next question is mostly for you, Dawn. So there's, I'm right here. Right here. Okay. Can you give a quick explanation? You do mostly EMDR. I've done CBT, EMDR, and DBT. Can you kind of explain a little about DBT, EMDR, for people who haven't done any kind of that kind of therapy? Because different things work for different people.
Can you explain those letters first?
Can I explain my what?
EMDR and DBT, can you tell them what it is? Thank you.
Military, any military veterans in here? We speak in acronyms, right? So if you don't know, it's like we went to the HAP for the HCT for the BRN at the SAC, right? So CBT stands for cognitive behavioral therapy. And that is, what Dr. Pena was talking about earlier and was again referenced by Dr. Neiman, that CBT assists the brain in sort of restructuring how we think about things. And that's why I call it the gym for the brain, because you're really disciplining the brain to think differently and really creating new neuronal pathways in so doing. And it just takes time to sort of, pave those roads to think differently. But it's evidence-based for treating depression and anxiety. So yes, we have the cognitive functioning issues, but then we also have the depression and the anxiety. And so it always takes effort, but it gets easier over time. So CBT, I think, is just outstanding for treating depression and anxiety. EMDR stands for eye movement desensitization and reprocessing. And it is a treatment modality that is used to treat post-traumatic stress disorder and what I really call the sucker punches of life. So I am an EMDR certified provider, and I use it to treat a range of things, from chronic illness diagnoses to couples, betrayals and relationships, to traumatic grief and loss, if somebody loses somebody very suddenly, or to suicide. The program in which I work deals a lot with suicide. So I use EMDR for those kinds of things, and that's why you're going to see on my resource slides references to EMDR, because it has the ability to, what I say, sort of help the brain file stuff that seems to be stuck, right? Stuck in the left hemisphere, stuck in the right hemisphere where our 5 senses are, which is why sometimes people say, I want to get over it, or I know it's in the past, but I can still be triggered, right? So we can manage the triggers with CBT, but if we want to further digest them and literally move them out of the body, EMDR is extraordinary for that if you have a qualified provider. So that's a whole nother subject, but you absolutely want to get somebody. It's a very powerful treatment modality, and you want to get somebody who really knows what they're doing, who follows protocol and knows what they're doing, because the research that backs it up if one follows the protocol. So, yes. And CBT? Oh, DBT. Dialectical behavioral therapy. Yes, so dialectical behavioral therapy is another treatment modality that assists people in regulating emotions and also perceptions of other and themselves, right? How do I perceive myself? And DBT is also evidence-based and does a fantastic job of emotional regulation and coping and relational coping. You are welcome.
I know all of these things we're saying that we need to do post are great, and I've done some physical therapy. But everything costs money and co-pays, and it's very financially devastating when you can't afford the extra $1,500 a month to go see all the different specialists. Is there anything out there, grants, anything that helps people find services that they need and be able to pay for them? And just working class, middle class people.
from the physical therapy perspective, I think that it's worth the money to get an initial evaluation from somebody who does manual physical therapy and who belongs to the group of physical therapists whose website says something like the Art of Physical Therapy or something like that. And this is a group that believes in balancing top and bottom, right and left, front and back, and will treat your ankle pain by manipulating your shoulder, and your ankle pain will get better. It's like magic. It's very amazing subset of physical therapy. And I think if you see somebody like that, spend the money, get an initial evaluation and an exercise program, yeah, you're out of pocket, whatever it costs for that initial, but these folks are pretty amazing at giving you home stuff, so that's sort of an in-between kind of an approach. I think there's a lot of things that you can get online in terms of physical exercises and things like that that don't cost a lot of money. I tell my patients, get a pair of sneakers and walk, but don't go any further than what you think you can walk back. So make sure you don't get stranded, far out. So I think from the physical side, I think there's ways you can do it. Around where I live, near DC, there's a bunch of massage schools where you can get massage at a real reduced rate, if that's a helpful thing to you. I'm a big Epsom salts bath fan. So I think there are some things like that, and I think it's useful. I was talking to somebody and saying, it's too bad we can't get the patients in little focus groups with each other, because you all probably know as many more things than what any of us can say that have worked for you, little tips and tricks like that.
We're gonna have one more question, but from a patient perspective, is there anybody that has found some additional funding resources that might be able to address that question?
I can chime in briefly.
Okay.
Sure. So in addition of a Master's of Health Administration and Systems Operational Management. So working with managed care, this is more for the U.S. patients, but reach out to your managed care plan. There have been successful stories with patients working specifically with Aetna and Care First Blue Cross, where they're able to work and get things like massage therapy covered. It's hard. You have to talk to the right people, and you're going to get dismissed more times than not. But there are ways that you can get those types of things covered. Maybe not completely, so you'll still have an out-of-pocket cost, but it is a possibility with managed care plans.
Thank you. So we'll have one last, and we'll do one moment of housekeeping items as it pertains to lunch.
I would also like to respond to the previous question. Georgie is a part of our regional support group, and bringing these people together to be able to talk through your issues on at least a quarterly basis. We're not very succinct in how often we meet or how long we meet, but Georgie makes her home available to us. And when I found this group, I think I was still in the height of my recurrence of Cushing. I'd already been through a bad Cushing experience. And I could think, holy cow, I get to go to a regional group and I have a licensed psychologist that's going to be able to help us. And I go to this regional group, and you all got to experience Amy Dom's experience yesterday with Cushing, and she's in our regional group. And then we're trying to meet together with Dr. Keel, because she also goes to our regional group. We happen to be in a geographic region, thankfully. Johns Hopkins University is the doctor I can draw from Cushing's disease experience, to come visit with us at our patient meetings, and he puts on a presentation. So I'm kind of pegging the doctors on the panels this week. I'm calling myself all the time a pushy cushy, because I'm not afraid to ask them. I say, can't you give us a time on Saturday when you could normally be with your family and having a relaxing time? Please come visit with us as well. So they say yes, and we're so grateful, because we have lots of questions to ask of them, and we get ideas from each and every one of them. It's hard to keep the Cushing group together. In fact, ours is in a lull right now, and Georgie and I and Amy and Dr. Kill are trying to figure out how to spark it up again and how she can utilize us, an immediate brain trust, to ask us, well, what about this? How do you all feel about that? And there's about 8 to 10 of us in the whole regional area that can bother to gather to meet, and you've got to imagine how difficult that is. Cushing's, when we're active, we don't want to go anywhere, and we sure don't want to have to expose ourselves and tell everybody about what's wrong with our life. But I promise you, there's just not a better thing to do if you can get the energy when you're fatigued, to get into your car and drive a short distance to meet with people who are dealing with all the stresses that you're dealing with and share. So I would say, what other things can you do if your insurance doesn't cover it, or if you don't have enough money? Hopefully you have enough gas money, and you go spend a couple hours with people who understand exactly what you're going through. So for me, Georgie is our rock star of our regional group, because she's always able to share with us the studies and interpret them for us, and does a marvelous job. She has a gorgeous house as well, so it's really nice to meet her. And she always has snacks and cookies and milk pads and everything. She's the ultimate professional, and I'm just so thankful you're on this panel today, Georgie. Thank you very much.